Good morning, afternoon, everyone. Thanks for being here. Our guest today is an inspiring researcher, for me at least, in the field of medical informatics. She's a professor at University of Washington you will have to correct me with the updated position. And she is very special because I think she's one of the few researchers that are acknowledged by both the HCI and medical informatics communities. Has won Best Paper awards from both communities as well. I think what's most interesting about her research is bringing forward the patient's perspective when technology is involved, before running to design and develop interesting technology. And she will tell you about the rest. Wanda, Pratt.
Okay, thanks. Thanks for inviting me here. It sounds like I'm getting a little feedback. Today I'm going to talk about my research, and I'm going to blend two aspects of it. I'm going to talk about the design thinking methodology, and then I'm going to talk about how we are using design thinking to address an important problem in patient safety. So just to get a sense of how big a problem this is, how do you think medical errors ranks in the causes of death in the US? Do you think it's 10, 1, 5? Any guesses? 10. Okay, we got into 10. A guess for 10. 6. Okay, great. So actually, it's, according to recent data, it's number 3. Somewhere between 250,000 people a year and 440,000 people a year die from preventable medical errors in the US alone. And this is just looking at the inpatient setting, looking at the hospital setting, and not really looking even at the outpatient setting where you're in a clinic and medical errors might incur there. So this is a substantial problem. Note it's third only to heart disease and cancer. We've known that this has been a major problem for a long time. In particular, the Institute of Medicine highlighted this problem way back in 1999. Then they had a very controversial report, To Err is Human, and they highlighted how prevalent this problem was. It got a lot of energy behind this problem. People started working in this area to try and address the problem. But the problem wasn't going away. So a couple years later, they produced another report called Crossing the Quality Chasm, trying to look at different approaches and different techniques to try and address this kind of problem. But even though it's been in the news and highlighted for over 18 years, it's still a big problem today. So like I said, there's a recent paper from 2013 that estimated that over 440,000 people die a year. If we think about that in an equivalent kind of complex systems of the airline industry, that would be about 7 airplanes crashing a day. So the scale of the errors is along those lines. Both kinds of systems are very complex, right? You can't just do a 99% error-free, because that means 1 out of 100 airplanes are crashing, or 1 out of 100 patients are dying. You really need to look at serious safety issues here. The study also looked at not just deaths, but serious harm, and their estimates were that 10 to 20 times that number are actually cause serious harm. So that's more like a fleet of airplanes every single day of the people who are being seriously harmed from medical errors. So systemically, this is a really big problem. But I find it even more motivating than general statistics to think about a story. So I'm going to tell a story of a person named John. John was having a variety of symptoms over a few weeks. they were confusing, but they started to get worse. And he was experiencing some pain in his chest and became very concerned. So he went to an urgent care clinic. Fortunately, there was a doctor there who was very good at communicating with he and his wife about the situation. And she realized that he'd been in and out of different doctors' offices for the same kinds of issues. So she spent a lot of time, where have you been? What have you been doing? Then she found out he'd recently been to Vermont and said, I think we should look into Lyme disease here. That can cause very confusing symptoms. So since he was having some chest pain, they did an EKG and found that his heart rate was very low, 42, and he had some irregularities in his heartbeat. It's called atrial fibrillation, also a second-degree heart block. Now, the doctor knows that this is a serious condition. This could cause the man to have a heart attack or go into a stroke. So she wants to send him to the emergency room. She sends him with the EKG and the note that she suspects that he has Lyme disease. So they go to the emergency room. They are seen pretty promptly. The patient, John, and his wife say, we'd like to have a blood test for Lyme disease, because this other doctor said this could be actually what the cause is of our problems here. And that was denied. I said, we don't do tests for Lyme disease in the emergency room. We can't follow up on that. We're going to look at your heart. That's what the issue is here. We can't possibly do a blood test for Lyme disease. A little while later, someone shows up in the emergency room with a pill. We don't even know who this person is, whether this is the nurse or the doctor. But anyway, they say you should take this pill because that's what's been prescribed. So the man and his wife question this. What is this pill? Why is it being taken? The presumably nurse says, this is metoprolol, which is a beta blocker, and he needs to take this now. The wife says, wait a second, beta blockers, don't they slow heart rate? But when he came in here, he had a heart rate of just 42. Are you sure this is appropriate for him to take? And the nurse says, absolutely, he has to take it right now. There's a real risk that he could have a stroke and die. It's essential that he take this medication. So he did. Unfortunately, they found out later that metoprolol is contraindicated in this situation. No one who has a heart rate of under 45 should ever take it. In addition, no one who has an AV block should ever take this drug. And in this case, John had both of those conditions. Unfortunately, a while after he was released from the hospital after taking that drug, he completely crashed. And when the paramedics showed up, they couldn't even get a heart rate or blood pressure on him. They were able to revive him, and he spent the next week in the cardiac intensive care unit and is now fine once they tested and treated him for Lyme disease. And this is a true story. This is a true story of my husband and I, just about 3 years ago. And just to tell you that this can happen to anyone. So this happened, whoops, don't touch my microphone, sorry. This happened right after I wrote the grant to support this work. So I already knew about medical errors. I knew all about it. I'd just written about it. This happened in one of the hospitals where I had a partnership for looking into patient safety issues. So just to show you that it can happen to anyone, anywhere, anytime, even people who are very well informed.
Has the culprit been punished for that?
That's an interesting perspective.
Without it, all the studies are worthless.
It is a hard situation, and I think that'll be a good thing to get to when we look at a little bit more of what causes medical errors. and what caused this particular error too. In some sense, there was a confluence of factors, not just someone's incompetence, but other kinds of issues as well. And yes, we did file an official complaint. It was a little tricky for me because I had a working relationship with the hospital. I had a grant proposal that was under review with the hospital. So not only was it a tricky kind of situation where patients are worried about any kind of retaliation if they speak up when you're in the hospital, it was actually my professional career that was at stake here too. So we tried to distance me from the issue and foreground my husband, who fortunately has a different last name than me too, which helps a little bit. So the title of this slide was Using Design Thinking to Improve Patient Safety. So the other part of my talk is how do we address this big problem of patient safety in a different way? And in my research, we're approaching this using what I call design thinking. Design thinking is really a methodology. It's a way of combining some analytical methods that you normally think of from an engineering perspective with highly creative methods that you think of more from a design school kind of perspective. So that's the thread that's going to be weaving throughout a lot of this research that I'm going to talk about today. And the definition that I've quoted up here is from the Stanford's Design School website. Now, this isn't something that I created. This has a long history that can go back even to Traces of AI, of Herbert Simon's book, where he talks about satisficing and seeing everyone as a potential designer. That had some of the roots of this design thinking approach. Some other people have taken some of those ideas and built upon them and expanded them and pulled them from different kinds of perspectives. Robert McKim looked at ways, his book in Experiences in Visual Thinking, looked at ways to try and incorporate the right brain thinking with the left brain thinking to really address serious wicked problems, if you've heard of that term. Nigel Cross talked about designerly ways of knowing, which was really looking at ways to pull in the way that designers think about problems and try to solve issues. And then further on, Susan Bodker and several other researchers from Scandinavia looked at the Utopia project and was really looking at this melding of engineering kinds of perspectives with designers' perspectives and really looking at participatory design, looking at throwaway prototypes for ways to increase the connection with the engineering side of building with the creative side of design. Peter Rowe from Harvard, I think, in urban planning, wrote the book called Design Thinking, and that started the term really going along those lines. And things really took off when Tom and David Kelly created what's arguably the most famous design company in the world, IDEO, which has a global presence now and has connected to the Stanford Design School. And then starting in about 2005, you could see the term design thinking and some of the techniques of design thinking really entering into curriculums, but still really mostly in design schools and schools of architecture and urban planning, not so much in computer science or information science and information schools. So in 2010, several of us faculty in human-computer interaction in the iSchool got together to really think about how could we infuse this new notion or this new trend of design thinking into our curriculum and to our research. How could we communicate it to others and explain what this is all about? So in 2010, we got together and created what we considered to be the 7 key parts of design thinking and how we were going to communicate it to others and pull it into our work. And I'm going to be using drawings by Andy Coe to explain these 7 key parts. So the first part is looking at the problem. The idea here is that depending on how you look at the problem, that influences the kind of solutions that you consider. So really a part of design thinking is being able to look at the problem from different angles, because depending on that perspective, you can widen your scope of potential solutions. So now let's go back to healthcare and the patient safety problem. What is the problem here? What do you all think? Yes?
I'm guessing that it has something to do with the handoff between different people working in the clinical setting. This person who is responsible for the care is someone that the patient hadn't seen before and hadn't communicated with before. So presumably that person was given direction by someone else.
Great.
Those handoff moments might be where errors happen.
Right. So healthcare is a very complex process that has a lot of communication, and any kind of communication problem in those handoffs is going to be a big issue. Any other perspectives? Mm-hmm.
Just the general complexity of bouncing from doctor to doctor and not having a sort of chain of custody of the ideas.
Right, so there's lots of different players involved. It's not just will they communicate, but who's in charge, when, why, how, all those kinds of things. Did you?
I would guess that it's because the system actually isn't designed to anticipate errors. Because when you have something working, when something goes wrong, you think it's that person's fault. But if you're not actually proactively assuming that there will be errors and how to prevent them, that would just be my guess.
Oh, that's excellent, and that leads into, I think that's kind of the perspective that you were talking about too, is a little bit of the bad apple perspective is pretty pervasive when people think about medical errors. They want to blame somebody. They want to say, oh, that nurse made a mistake in giving you the drug, or the doctor is really at fault, they're a bad doctor because they prescribed this drug and they should have known better. But actually, most of the work shows that that's not really the problem. It's really much more of a systemic issue of dealing with very complex system. An excellent researcher in this space is James Reason, who's looked at this problem from a complex systems perspective, that there's going to be a set of hazards no matter what. Healthcare is that way. The airline industry is that way as well. And the idea is, what can we do to try and prevent those hazards from actually resulting in some kind of loss or a medical error that causes some harm? So the idea is, can we put up these blockages, knowing that each particular block is never going to be perfect, but can we come up with a series of really good ones that hopefully the Swiss cheese kinds of holes don't line up and actually cause harm, but maybe if we have the right kinds of blockages, they can address different components of the hazards and prevent a real loss. A great example is surgical checklists. Has anybody read or heard Atul Gawande speak of this? Right, so he's a very eloquent writer. He writes for the New Yorker and has several books along these lines that talks about this issue. And you can think of it as kind of similar to the airline checklists. I don't know, has anybody flown in a small private plane? So the pilots have this checklist. Every pilot does this. They go through this checklist. Did I do this? Did I set this right? Are the flaps right? Has somebody checked that? Those are the kinds of things that now they're instituting in surgery rooms as well to try and get this issue.
Yeah, so I've heard about these for years, and I've also experienced many medical errors in family and friends.
Yeah.
And it struck me that they're great, but very limited in the settings in which they really stop up the holes. But that's anecdotal, and I'm wondering if there is any systematic study of which environments checklists are really useful in.
Yeah. I don't know of specific studies, but from the stuff I've read and seen, it seems like as much as you can systemize a process, then these kinds of checklists are really important, which is, you could see that's why surgery, I think, connects with this more than primary care, right? There's things you do to prep the patient. Have they, have they been intubated? Do they have the tube down so they can breathe? Do they, have you checked that you're operating on the right body part? And then in the closing, have you removed all the sponges? Have you counted them? So some of those kinds of settings where there's some consistency in the process and things you constantly have to check for, I think do lend themselves to that. But like I said, that's really just one slice of the Swiss cheese. We can't think that we're going to solve the whole problem with just that slice of Swiss cheese. Yeah.
I'm curious, when you hear that certain hospitals have outstanding reputations, and you look and say, what is it that they're doing that other hospitals do? Is it a matter of money? Is it a matter of training? Is it a matter of a decrease in bureaucracy? What is the distinction? Because usually people know if they live in an area, go to that hospital if you have this kind of problem. Don't go to that one, you're sure to die. That kind of thing. What is it?
Yeah.
Do observation. The ones that perform well, what are they doing right?
So if I had all the answers to that, I would be a really popular person. But I will say, it's complicated, right? And that's why I noticed that you said for this condition, right? Mm-hmm. So that's pretty key. Often different places have different kinds of routines and specializations and have worked hard for that. So they have reputations in those areas. The government has tried to create some regulations and some recording to try to deal with this issue, but it's very hard because healthcare is complex. One challenge is a place like Harvard, where I don't have to call out which medical system, but the sickest of the sick are going to come here. If they're not so sick, they might go to their community hospital. So actually, there might be fewer deaths in the community hospital, but it might not mean that they do it better. It just means that the people who are here are sicker, and so their care is more complex. They're more likely to die anyway because they're sicker. And so it's very hard to look at any kind of generalized statistics and say hospital A is better than hospital B because there are so many variations. But a key thing is to look at some of these processes and are they putting in some of these structures in place to try and limit the hazards that happen? Some other kind of examples are medication barcodes that are pretty commonly used now. Who's been in the hospital or had a loved one in the hospital? Have you seen these barcodes being used? So the typical way is your medication, if it's a pill in a bottle or an IV bag, has a barcode on it. And the person who's giving you the medication will scan the barcode. And then on the patient's wrist is a bracelet that also has a barcode. And they'll scan the barcode on that. And then the system will make sure that actually this is the correct drug for the correct patient to try and make sure that no error happens along the lines there as the bags don't get mixed up or the bottles don't get mixed up. And that's another type of blockade that they're trying to put up to systematically look for ways to block these hazards. Yes?
So in the case of medication barcodes, the error that they're meant to stop is someone giving a medication intended for patient A to patient B.
Correct.
But they don't necessarily say things about whether the medication that patient A really has been directed to receive is actually contraindicated for the patient.
Correct.
They're not that specific.
No, they're not. They're just looking at, does this match the order? Is this the drug that was ordered for this patient? It is not looking at, was the order correct in the first place, which was clearly the issue for my husband, John.
Yeah, also Bob Walker has a really awful story of somebody getting orders of magnitude more of a drug.
Yeah.
And they did all the barcode checking. It just was a bad order.
Yeah. There are many tragic stories that have way worse outcomes My husband's did. So this is the problem, and people are thinking about it from good angles. So what angle am I adding here? So here, we are looking at recognizing patients and caregivers as a potential blockade, a real safeguard in preventing medical errors. Right now, especially in the inpatient setting, in the hospital kind of setting, patients are viewed much more as just black boxes. You just do things to them. You don't get their opinions, you don't tell them what's happening to them, you don't interact with them in that kind of level. Often it's just, we've decided what we're gonna do, we just do it, and we see what happens, rather than as actual integrated care partners, which fortunately is happening more and more in the kind of outpatient setting, but has yet to really transfer into the inpatient setting. And that's at the heart of the way that we're reformulating the problem, is that patients are not really perceived as playing a strong role here. So the one way that patients have been asked to play kind of a safeguarding role is more like police officers for hand washing. Right? Has anybody experienced that? Right? You see the signs all over your doctor's office. Ask your doctor to wash his or her hands. That is one way as a safeguarding, but that isn't necessarily respecting them as an active participant in the healthcare, as in intelligent people who help know what's right or wrong for them and what their perspectives are. But a question I often get around that line is, do patients really want that? Are they ready for that? So recently, the Society for Participatory Medicine did a big study, a phone study of, I think it was over 2,000 people with a range of ages, races, and regions of the country, talking to them about these kinds of issues. And they found that 88% of them, by far the majority, believe that working with their healthcare professional as a partner, not just as being told what's happening to them, but really being an integral part of the process, will help them manage and improve their overall health. So we have some data that says that people really do want to do this, even though now often they don't have the tools to enable them to play this kind of role. And they even found that when you even look at people monitoring their bodies, and that 77% really wanted both equally to be a part of this, to be a partnership, rather than the healthcare professional only. Even more people thought that it should be themselves only than just the professionals. So here we're really talking about ways to engage patients. And e-patient, I love their logo, that's enabled, engaged, equipped, and empowered. So how can we set up this ideal e-patient setting to reduce patient errors? So how can we use that e-patient to add a slice of Swiss cheese and prevent medical errors? Yeah.
So two related questions. One is when the patients are unconscious or they don't have family members or other caregivers who can play this auxiliary role, you would think that perhaps unconscious patients would actually be more vulnerable in general to these kinds of errors, and then this sort of would compound it. And then the second question is just on the cognitive load on medical professionals in terms of all of these procedures for barcodes and scanning, whether in the process of adding these safeguards, it takes away from the health professional actually thinking about what the drug they're administering is, because they have to scan all sorts of things and enter kind of safeguards, and that actually decreases safety in some sense, whether it might do that.
Well, typically, those are great questions. I think that the reason that a lot of these technologies and perspectives of having an engaged patient has started more in the outpatient setting is exactly what you're talking about on the inpatient side, that sometimes the patients are unconscious, or they're coming out of surgery, or they're super sick because otherwise they wouldn't be in the hospital. So yes, part of what we're doing is looking at a caregiver's role in that. Sometimes those are local caregivers, sometimes they can be distant caregivers. Right now there's no way for a distant caregiver to really play a good role in this kind of process. But through technology, there's no reason why they can't at least play some role more than they are now. And so we're looking at those kinds of things. Other places also have patient advocates who are paid people who can play this kind of role. The challenge there is that a patient advocate isn't ever going to know the patient as well as the patient themselves do or a caregiver. But certainly it's better than nothing. And then your other question about some of these safety procedures also making their own errors. Certainly that's a worry. And now IT, information technology, has certainly been promoted to solve these problems of patient safety. But more and more, there's been a variety of studies that show that they cause as many problems as they solve. Some people argue more in some certain circumstances. So that's certainly something that needs to be looked at and carefully studied. In particular, workflow kinds of issues are really important in this kind of complex care setting, and different people's roles and what kinds of role interruption plays and who does what. Typically, in a hospital setting, the person administering the drug is very different from the person prescribing the drug. So in that particular example, that safeguard doesn't interfere with distracting them when they're making the decision. But your point is important there.
But you don't think what you going, I agree it's good, but my mom was a nurse, and through the career, like she always used to say, before they spend much more time talking to the patient, and as budget were cut, and they were always asked to do more and more. At the end of the career, they barely had time to talk to the patient. Like they come, they did the care, and they went away. That's all they could do anymore.
Yeah.
You know, they could. The nurse probably did some of that before, but they don't have time to do it.
Right. That is certainly a challenge in the current healthcare environment. Absolutely. The designer's perspective. Excuse me?
In the current health business environment.
Yes.
Money is that corrupts everything.
Although, you know,
That's the problem.
healthcare is going to
The
cost
bottom
no
line.
matter what. So it is a very big challenge. The hope is that if we can automate some things to make them faster and easier and safer, that enables more of the engaging personal interaction. We have yet to see that that's really going to happen. So I'm going to get back to this issue and look at how that translates into the project that I have. I got a 5-year, $2.5 million grant from the Agency for Healthcare Research and Quality to really look at this perspective. And we had 3 aims to really look at understanding how increasing the patients and their caregivers' situational awareness of what's supposed to happen to them, what is happening to them, what has happened to them, how that can help them play a safeguarding role. Understand how patients and their caregivers can capture and manage their own healthcare information and use that to play a safeguarding role. And then a key part is this communication, as others have talked about too. It's not easy to speak up. Even the simple thing like hand washing, where there's signs on the wall. Has anybody struggled to do that if they saw their doctor come in without washing their hands? It's hard. So how can we look at some new ways to support that dialogue in a less intimidating way and really make sure that the conversations happen that need to happen, or using technology as a mediator to lower the barrier for those communication issues. So now I'm going to talk more about how we're using the different parts of design thinking to address the aims in our grant and really look at this patient safety problem. So one part of design thinking is really melding this aspect of convergent thinking, which we think of a little bit more in the healthcare space and in engineering. How do we solve a problem, narrow in on the solution? But if we can merge that kind of thinking with a divergent thinking that's more common in design schools, where we look at creativity and maximize the possibilities, if we can merge those two kinds of thinkings together, maybe we can come up with some new kinds of solutions that will be helpful. So now I'm going to talk about how we're doing that in this project. So we're following a 3-phase methodology for this project, and it's the first phase that really looks at ways to increase the divergent thinking, because that's the part that isn't happening as well in the healthcare system and in the information technology to address those problems. So we're doing divergent thinking by using interviews and observations to look at the problem a little more holistically and get more input on what's actually happening. So the way we're doing that is we have partnerships with 2 different hospitals in the Seattle area. One is with Virginia Mason, which is an adult-only hospital, and the other is Seattle Children's Hospital, which just takes care of children 7 to 18. Sometimes they end up with up to 21-year-olds in there as well. And we're trying to be responsive to diversity, both in terms of ethnicity and gender, as well as the type of patient, whether they're coming from a medical ward or surgical, and how complex their care is and their situation is. So we've done over 118 hours of clinical observations where we shadow various kinds of clinicians around the hospital, looking at information flow between clinicians and from clinicians to patients and their caregivers, as well as then talking directly with patients and their caregivers. We have 14 patients at each site, and we're able to get caregivers more at the Seattle Children's site than at the adult hospital, but also doing lots of interviews and observations with them as well. And at a high level, some of the things that we found, which if anybody's been in a hospital are probably not too surprising to you, is that the patients really have very little access to information. You think as when you go into the doctor's office that you might have little access to information. At a hospital, it is much worse. Things are happening quickly. You often have no idea what medication is being administered to you. You don't know what's going to happen to you in the next 5 minutes, let alone in the next day or 5 days. Don't know what the plans are for when you will be able to leave the hospital or what has to happen before you can leave the hospital. A lot of that information is missing. Now, clinicians do try to provide some of that information, but usually that happens in a verbal dialogue, often through a process that they call rounds, which, are people familiar with that term? So the idea is the clinical care team get together and they go visit patients in their room, and that's usually when they often talk amongst themselves about what's going on with the patient care using highly clinical terms, often a very structured format, sometimes talking very quickly. And the patients and the caregivers are trying to suck up as much of that information as they possibly can, but it's very challenging, especially if you have a patient who maybe is in a lot of pain or just came out of anesthesia. So they're already in a state that isn't as receptive to that information, and now you're making them get it through a verbal form. And that really is by far and away the only way that patients and their caregivers get information. So that leads to a lot of their information needs being unmet. They have no idea what's going to happen to them when. They don't know their schedule or anything along those plans. And so we found that from the patient and caregiver's perspective, their information needs and the information work that they need to do to keep themselves safe and healthy is largely completely unsupported. So there's a number of barriers that we found. Like I talked about, the receiving is a problem. even if the physicians or the care team were very clear, the challenge is it's complex. There's usually multiple units involved. Sometimes they get conflicting information. Sometimes they don't know what each other are doing. We saw clinicians come into a patient's room and be surprised that the patient wasn't there because they had physical therapy to go to or something. So it's even a challenge among the clinicians not knowing what's happening when. And then what we weren't anticipating as much is how many patients and caregivers were very frustrated by their inability to supply information, sometimes really important information. They don't know who to tell what. Half the time, actually, most of the time, they don't even know who's in their room. They don't know if this is a doctor, a nurse, a janitor, a nurse's aide, but they have a need and they communicate it to whoever happens to be handy. That person might not know what to do with that information. They might be very busy on their way to something else and it doesn't get handed off. All of these kinds of things happen just from the perspective of the patients being able to give information back. Let alone any of the social pressures of, I don't want to be a difficult patient. We heard that a lot from patients and caregivers. They don't want to be seen as the difficult one because then they're worried that they won't get as good a care. This is a quote from one of our participants in terms of having information available. Most of it I scrawled on the back of some pamphlets that came out of a box of dressings because I didn't have any paper. They did have a whiteboard in my room, so I could keep track of some of it there, but some of it was embarrassing, and I didn't want it available to be read by anyone who walked into the room. I think this is an important issue that a lot of people don't think about. It's not just getting them the information and making it visible, but that some of it can be sensitive or private, that they don't want to share with Aunt Mary who walks in the door or their next door neighbor who happens to come in and visit them. Another one talked about, this was a parent particularly in a children's hospital. We spent a lot of time sitting around waiting for the doctors. Then we would go to the bathroom or go get food and come back, and they would have been there without speaking to any of us. We would have to wait a whole nother day to ask our questions or share information or observations. And we heard this complaint a lot. And there was only this one time when the doctor's in the room where they could even get this information. And they didn't know when this was going to happen, who was going to be there, how long it was going to take, and they have other needs to satisfy too. Parents sometimes have more than one child and they have to be home for that. They have jobs, they have a life too, but yet they needed to be there at the right time and place. So transitioning in the design thinking process of how are we going to, now that we've kind of gone to do some divergent thinking and seeing the scope of the variety of kinds of problems that patients have, how are we going to solve some of that? We're going to use the design thinking about externalizing ideas to make evaluating them easier. So mostly what we've gathered in the first part is that the patient's conceptualizations of the process, of the problems, what they think their needs are, the problems they're experiencing. But now let's look at how do we externalize some ideas along these lines. So what we did here is use a participatory design approach, really involving patients and caregivers as part of the design process. It's very much a human-centered design approach where we're looking at sharing control of the design process with the patients and caregivers, as well as sharing our expertise from a design perspective, as well as them sharing their expertise as a patient and a caregiver, and looking at ways to use that process to motivate changes and to learn from each other. I like to think about this in different kinds of dimensions. And if the goal is to really understand the problem richly and what potential solutions are, we can examine what people say, which is usually what happens through the interview process. And we gather some really useful information there. And then we look at what people do. That's usually what we do when we do observations. And we get a somewhat overlapping set there, but we usually find out new things that we weren't anticipating just from doing what people say they do. And then I think what's often missing is this third piece, and that's what people make. And we find that we learn even more about the problem space and potential solution space by really looking at what people make to solve some of these problems. And that's the stance we've taken to do some of this participatory design. So our approach is we have one session which is with just the patients and caregivers, because we want to make sure that they have a voice that isn't squashed necessarily by the clinicians and other care team because of power dynamics. And then we try to bring all the players together in a series of 2 different sessions to look at what if you mix patients, caregivers, and healthcare providers together in designing solutions. So the way that we ran these participatory design sessions is that we would introduce the project and the general problem of patient safety, convey at a very high level some of our kinds of findings, but keeping that more to the 5-10 minute space. And then we do some individual design warm-ups so that they get in the space of doing design. We had a great activity that we used that one of my team members created, which was having everybody create an ideal Band-Aid. So what are some problems with today's Band-Aids? Sketch out your new perfect Band-Aid, not worrying about what's technologically feasible or possible. And that usually gets people's creative juices going in a less intimidating kind of way. And then we do a whole group share of the problems. What are the problems that people see in this space for patient safety and the patients getting the information they need? And we share that out. And then we partition people into groups, and they pick a problem to address, a problem that's been discussed as the whole, and they design for that to address that kind of problem. And then at the end, they share their designs. The sharing designs connects to the 4th part of design thinking, which is really this way to share with each other these group critiques so that you can see what works, what doesn't from different people's perspectives. I think this is particularly important for the mixed group sessions when we're involving patients and nurses so that they can talk some about potential challenges they see in incorporating some of these ideas. So now I'm going to talk about some of the things they made, some of the designs that they came up with, and how that connects to this problem of patient safety. One of the designs they came up with was called dealing with the problem of sharing out. Has anyone ever gone to either their doctor's office or the hospital? How many times do you get asked what your drug allergies are? 2, 3, 4? Yeah. So they talked a lot about this issue, that the burden of repeating the same information. Now note, it's not just annoying that you keep getting asked this information, but what if you're really complex? What if it's hard to list all of this information? There's a real danger of forgetting something because you've said it once, you assume they then know it, and then you forget to say it a second or third or fourth or fifth time, and that time happens to be the person that really needs to know it. And they're depending on talking to you to get that information rather than looking at what somebody else wrote in the chart.
There's also, I've experienced this not only personally, but with my 90-plus-year-old mother. It's also, you have this sense, well, I told you, you put it in some record. How can I trust anything if I can't trust you to remember this list?
Yeah.
And anyway, you had the list from before, from the last visit.
Yes, so I think that is an issue, and we heard that.
Lack of trust that develops from this, I think.
Yeah, we heard that expressed from patients and caregivers too, is that not just this frustration of the burden and the worry about the danger, but also this like, well, how competent are you if you have to keep asking me this so many times? So it did influence the patient's and caregiver's perspective of the setting. So what did they design to do about this? This was cute. This came from one of the kids. The kid was drawing a design of the problem. So the parent is saying, our child does not like root beer anesthesia. I didn't even know that anesthesia had a flavor. But evidently this kid really hates root beer and was kept given the same flavor that he absolutely hated of anesthesia and could not get it through to the care team, don't use this. That sounds like a small problem, but these issues all add up to the patient's sense of well-being and listened to and respect in the system. So this is what they designed to address this, was to have some kind of, and this was obviously in the pediatric setting, but could also apply in the adult setting. They have a child's website here, where they would have some of the medical things like your allergies, the current medications you're taking, your medical history kind of thing, the standard thing you're often asked a half a dozen times when you get in, but also had a lot of other ways to present information. They all felt this need, also having the same kind of perspective that healthcare was more depersonalized, that they felt like the team didn't know them or who they were, what their needs were, what their preferences were. So they wanted to create a video of who I am and what my preferences are, those kinds of things to really try and humanize the process a little more than what they felt like it was now. The other thing I also really liked here is that for the children, they wanted to also share what scares me. And it makes a lot of sense, but not just from a child's perspective too. Adults have fears too. And the clinicians were really excited about this because they realized that knowing that information really affects their care. If the child is really afraid of a needle, then they can do things to try and support that and address that fear rather than making it worse. So having that kind of knowledge being really important. Now, one thing to note is in a lot of these designs, like I showed, the important part is to really understand deeply what their needs are and what they're trying to accomplish here, and a little less on exactly how it's being implemented. That can happen on a design team, also in consultation with patients. But here we're really trying to maximize ideas and creativity. Another component that they talked about was ways to look in and understand what's happening there. Has anybody used One Bus Away? It's popular in Seattle, but I looked and it's in beta here too. The basic idea is it's an app on your phone that tells you when you can expect your bus to come. So it says, the bus route 2 is delayed. You should expect it in 8 minutes. So it's a real-time kind of update of where your bus is and when you can expect it. So you can see that this would be really helpful for catching a bus, would also be really helpful for understanding when the doctor is coming into your room and what you can expect. So one of our teams created this app called One Doc Away. And the idea was building off of the success that they saw of One Bus Away, how can we know when our doctor is going to come visit us? Obviously, there are some constraints there too, but everyone was understanding of things are going to be variable, just like they are with a bus. There's traffic that get in the way, things get delayed, but having some sense of, are they the next patient? Are they the 4th patient down? Giving a little bit of a clue of what's happening. Another thing they looked at is that lots of people come into the hospital room and you have no idea who those people are. Yes, they are probably wearing a name tag that, especially if your eye's like mine, there's no possible way you can read what role they are or what their name is or anything. So it's a very challenging kind of situation. Also, we talked to caregivers who really didn't know and wanted to know who's been in my child's room or my parents' room or my spouse's room while I was away. Or even from the patient's perspective, when I was asleep, who came in? Or when I was so drugged out from the anesthesia, who did I talk to? And really getting a sense of that. So they developed an app called Identitron, where they had photos of people and information about their role. So they would know whenever somebody came into the room, it would be logged into their Identitron, and the patient could look on their iPad app who this person was, what their role was. They could dive deep and get more information about them, know what kinds of things they're supposed to do. And some people really wanted to know a little bit of more personal information too, to try and make a human connection. Yes?
Getting a little ahead of things, but the examples that you've shown so far have all been sort of app store-like solutions that seem to be something that you expect people to be able to access using personal devices. Is there any concern about the fact that the people who have probably the largest information barriers are also the people who are least likely to have access to those consumer devices and those applications?
Yeah, so the question is about access to the technology. Well, here we're talking about an inpatient setting. So in some ways that works a little bit better in that some places actually there's some experiments happening here where patients are given an iPad when they enter the hospital and are able to use these kinds of technologies to get this information. So I think that's one thing that helps address it in a hospital kind of setting. Another aspect was looking at ways to help learn for a partnership in sharing what we would think of as traditional medical record information that is often not available to patients, but also having ways for them to provide information to update clinicians as well. Our kids created a cool little device called a instant communicator where their parents could instantly connect with other clinicians and communicate about challenges that they saw. So that's a sum of how we looked at externalizing ideas and group critiques part of design thinking. Now we're going to move on to talk about addressing another component of design thinking, and that's the notion that failing is a good thing. Failing helps us learn about what is good and what makes something good. We just have to make it easy to fail and educational to fail. So what are we doing along those lines? So what we decided to do was to do something with help letting people take some of the functional components that we thought of from our previous research and let them pull it in to design their own app and talk about it. So this was an easy, lightweight way where we could somewhat sketch out some of the ideas we had and then allow people to choose from the things that were helpful to them, talk about what was helpful, talk about the things that weren't helpful, and so on. So some of the examples here, this was a sheet that they could use to get updates about their health status. A big failure was this one. We'd heard from people that they wanted to know what the doctor really thought about their situation, but they hated this. One, it was too simplified. They felt like it was too kiddie, and they didn't know what were they going to do if their doctor gave them the frowny face. So having this way to really quickly and easily get that kind of sense of a failure and what we learned from that was really important. Some other examples of what we did is we had different kinds of components about doctor-patient communication. We had other things that were focused on safety, looking at ways that patients could see what other patients found valuable and frequently asked questions, provide a kind of safety checklist for them for their particular situation, and get that kind of information too. Another part of that that's kind of related to being able to fail easily is this sense of emotional distance in ideas to encourage critique. So we did this by using some low fidelity prototypes, so implementing some doing some sketching with an app and creating an interactive, but yet quick and easy kind of prototyping to get feedback. So this is an example of that, of having some kind of news feed design to let them know of what's coming up next and getting some real-time feedback along those kinds of approaches. Or diving into medications. Medication errors are pretty common, so that's something to really focus on as well. Looking at, what will this drug be like? What are other people's experiences? What should I be looking out for here to let providers know? What kinds of things can I expect, and so on. And then another component of design thinking, the last one, is really looking at articulating the rationale. We can't just willy-nilly pick designs, but we need to understand why we make choices that we have and what's the reason for them. There's a variety of reasons. Obviously, the totally arbitrary is the one we try to avoid here. So we're looking at more like the running a user study as a component. So right now, we are in the process of doing some of our mid-fidelity prototypes, putting them on iPads and delivering them into the inpatient setting, and looking at the ways in which patients and their caregivers would use that. And then we'll be transitioning to more high-fidelity prototypes where they'll actually get their own patient data and see how they would use that to really help us understand their needs more deeply. So that's really the third part of our phase, is really deploying these prototypes and really understanding what works, what doesn't, why, and how. So as a summary, these are the different components of design thinking and how we use that to really address the problem of patient safety, looking at it by reformulating the problem as patients need to be their own safeguards, and how can they be supported to do that. So lessons so far, we really focused on this situational awareness part, looking at designs for sharing out, looking in, learning about what's happening for more of a partnership relationship, connecting across the hospital, and having efficient and effective communication. So what if we go back to John's example now? And we look at some of the designs and the ideas we've had for addressing this problem. Does it help? So if we think of giving the patient, when they go into the emergency room or the hospital, their own iPad with their own system of information, and that they know when a drug is prescribed at the very start, that they can get an alert on this iPad, and that they can see more information about this drug, like when it shouldn't be given, what it's for, why it should be given. And they have access to their information to know what their heart rate was, what their different diagnoses were, that there was an atrial fibrillation, so that they can notice these potential discrepancies and raise a question about that. That's the key that we're trying to address here in this work and really try to prevent some of these kinds of problems. So in sum, the Patients as Safeguards project is really trying to enable this holistic e-patient model by providing them with the information that they need for a really good partnership of working together with caregivers, patients, and all the healthcare provider team to make a safer environment for everyone. I want to acknowledge this is a big team that's been working on this research, on our funding agencies and our partners. And then I'll just close with a list of some of our recent papers on this work. So thank you. Yes.
So it seems clear to me that the types of technologies and apps that you're talking about will improve the patient's experience. But how, or what's your thinking about kind of evaluating how much of a dent it actually makes in the medical error problem that you started out with?
Yeah, so I mean, certainly I connect it back to the story of how, and we have lots of stories of how that helps. My work is focusing a lot more on the creativity aspects of the designing new things. Obviously, the next step would be the gold standard from a medical perspective of, well, what if we deploy some of these things? How does it change the percentage of medical errors? That sounds easy. That's really, really hard. One, because those things are really not tracked well now anyway. So it's going to be hard to figure out if it makes a difference because you don't even know what the current rate is in any way. There are lots of systemic and legal and societal barriers to collecting that information because you don't want to have your hospital be the one that they consider unsafe and not go to. So it's tricky, but I think that's where we should head, is really do some studies to look at how is it going to improve things? Is it going to make things worse? Yes?
My concern would be that some of these models of information sharing, especially the ones that digitize all the information on a given web page, would actually mean less verbal communication between the physician and the patient. Because the patient might think to themselves, oh, you know, my drug allergies are on my sheet, and then there's no need to share them. And if the physician is not equally receptive or isn't taking the time to sort of read that information beforehand, that could cause a lot of issues. So I'm wondering, is there a movement toward educating healthcare providers? Is there an equal amount of this design thinking happening on the provider side?
So, so there's a lot of great issues there that I agree are a problem. So traditionally, the approach to patient safety has been exclusively on the provider side, so this is adding a different dimension. But I think ideally, we really want to work together and see how to make everyone's work well, because that's in the patient's best interest as well as the healthcare providers. So I think it does take a conversation of looking at things holistically along those lines. I can say in the outpatient setting that has been an expressed worry before. So there's been this advance of patient portals, of people used patient portals where you get some of your healthcare information. So physicians for a long time were resistant to that for exactly some of the reasons you talk about there. Through the open notes projects and other kinds of projects, we've found that actually the dialogue increases and is much richer. The physicians are more satisfied because their patients can actually understand what they're talking about now because they're more prepared for effective dialogue. There obviously can raise some conflicts too and some misunderstandings, but overall it seemed like the positives hugely outweighed the negatives for that increasing availability of information. But yeah, that's something to pay attention to and watch out for. Yeah.
Don't you think some of it was the job of the nurse, which was actually, the person who spent time with the patient and also talked to the doctor and was able to verify contraindication? Because, if the nurse who looked at your husband has met him before instead of just coming in the room, giving them the medicine and going away, that's what happened, right?
Yes.
If she had taken care of it from the beginning, she would have spotted those things because she would have known and checked them.
So that kind of gets at the bad apple approach, and I would argue that that's really hard.
I'm not saying it's the fault of the nurse. I'm saying it's the fault of the system that the nurse can't do that anymore.
But even so, I think the challenge here is that the system itself is so complex, that there are so many things that can go wrong. It's really hard for any one person in the system to know that. So John's example was actually fairly simple. If you have 97-year-old patients who are on 10 drugs, they actually don't even know what the drug-drug interactions are for that scale of things. There aren't any studies to do that even. So for any person to know that and manage that, I think is really, really challenging. Although clearly there is a benefit to getting to know the patient more richly and try and act to solve some of these problems.
Just make a side comment before I ask my question, which is the intense time pressure all of these people are under and the slices they get are clearly a contributing factor. It's not clear we can fix that. But I kind of want to go back to Salil and Gabriella's questions because I had a related question. It strikes me that you focus so far on what information to give the patients and their caregivers so that they know more and can ask more. But you also have a window here to empower them to ask. That if one were to build into this technology, not just knowing that here's something you might want to ask about, but kind of feedback, like did you get an answer? I don't want to try to design on the spot, but we've seen over and over in our work with the kids and their parents that they're afraid to ask. And just an anecdote from my own experience, I'm on a board of advocates for a women's health center. I was at a meeting in which almost all I was the least well paid of all the people in the room. They were bank vice presidents and I don't know what else. And their biggest issue was that they were afraid to bother their doctors asking a question. So it's not just people, it's worse if they don't speak the language and it's as a first language, and it's worse if they're low socioeconomic status, and it's worse if they don't have resources. But if it's true of vice presidents of companies, it's just so prevalent that it seems that it's not only giving people information, it's kind of giving them the courage to persist. And I'm sure you persisted with your husband, so even persistence might not be enough, but without it,
Right.
you're cooked.
Yeah. I do think that is an important part of it, and that is part of our aim, is really supporting that dialogue. And we are definitely looking into some of that for our future work. Some of the things that people came up with were not just having a place to ask questions for their care team, but to track, who saw this question? Has this question been answered? Has this issue, some of them aren't even questions. They're like, I'm freezing cold in here and I need a blanket. Who has seen this request? What's the status of it being addressed? Because sometimes those requests just get completely dropped. There's a shift change. Nobody even knows it's a request anymore. And those kinds of things can happen along the way. So yes.
Thank you very much for the talk. It was fascinating. I was just wondering, in this kind of research, how do you measure success? And the patient, not success in reducing the errors, not how happy the patients are. Mm-hmm. So.
Well, I think that depends on your perspective. From the funder's perspective, they want to see us publish papers, so hopefully we're succeeding along those lines. From my perspective, I want to change the system. I want to really make a difference. And I want healthcare providers, healthcare systems to see these kinds of possibilities and adapt some of these ideas into their own system that work for them, and really make the hospital environment a place where patients really can be deeply engaged in their care, and the caregivers. That's a hard question, and we're certainly not going to know that in this grant. I think that's much more longer term, and for future kinds of studies to look at that. If they adopt these kinds of technologies or these kinds of changes to the workflow or structure of the system, do our lives saved? Are the patients happier? Are the caregivers happier? Are the clinicians happier? Are they? All of those kinds of things are important questions. They're really hard to answer in a good way.
I think one of the most challenging things here is, we try to find solutions for the patients. We try to find technological solutions, but one of the most difficult things is changing the clinician's workflow. And in some of the observations that I've done, they tend to round outside the patient's room in order to avoid being asked questions and prolonging the morning rounds. So, we can provide, good technology that supports all the very important things that you were talking about, but it seems like there's a mind shift that needs to be done for clinicians to have more patient and family-centered rounds, and that should be an organizational thing that is a crucial part.
I completely agree. And actually, we picked these two institutions, because they're already very pro-patient, they want to do this. The Children's Hospital already has a family-centered rounds practice. They're looking at things like setting up appointments for visiting rooms and stuff. So these are institutions who are most interested in making a change and wanting to be involved. And so I agree it's a problem that needs to be addressed at the medical education level too, and really spread. But hopefully some best practices can be instituted in the places that are open to it, and then hopefully spread to other places and through education make a difference. But it's challenging. Yeah.
Yeah, I had really similar questions, and I wonder, even in a setting where the clinicians are really on board with what you're trying to do, if you run into cultural inhibitors, legal inhibitors related to patient privacy laws and HIPAA, where there are things that make it sort of systematically or structurally difficult for patients to actually get at the information that is being tracked about them already. In some respects, my sort of immediate thought is like, can patients read their CRCS? And that's, leaving aside the question of whether they can sort of understand the material that's included in them, is that something that is actually possible from a legal perspective, from a sort of hospital management perspective, from a compliance and risk management perspective? What are the things that you see as sort of outside the technology and the tools as obstacles?
Yeah, well, so one of the great things about HIPAA is actually, despite the way that some places use it to inhibit information flow, the whole point was actually to give patients access to their information. So because of that ruling, that helps enable it in some ways. However, an area that's very challenging is adolescence. So there are also rules about 13 to 18-year-olds, and how each institution deals with that is different. So the intentions can be good. They don't want certain private information, like whether a teenager is on birth control pills, or might be pregnant, or is sexually active, any of those kinds of things, or has a STD, a sexually transmitted disease. Clearly you want to protect some of that information, but on the other hand, if you have a really sick child, some of the solutions now are to cut off all access to parents to any of the child's health information at all. So even these patient portals that are available, a lot of places, once your kid hits age 13, you are cut off of all access to all health information. And because the kid is under 18, the kid doesn't have access to their information. So now you've gone from a place where you're used to getting information, and now there's this blackout zone for 5 years where you get nothing. Your kid gets nothing, the parent gets nothing. And so that actually has been my biggest frustration, is how to deal with that. And we're still working through that issue with the Seattle Children's Hospital. Thanks.
So thank you, Wanda, very much. This was
Thanks.
great.
Thanks.